Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the fern.org website or on our YouTube fern.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Now, let's talk about our spontaneous episodic vestibular syndrome diagnoses. One quick note on quote spells. Recurrent similar non-provoked episodes or spells should be addressed systematically. We should consider a possible seizure etiology. We should consider complex partial seizures as a possible cause. Patients with the seizure disorder may have dysconjugate gaze at baseline, especially those with autism, and you must note that prior to examining these patients. CNS ischemia may also be the cause of spells, including posterior circulation stroke and/or TIA, and posterior circulation ischemia should be considered, or posterior circulation TIAs, if the patient has recurrent, similar spontaneous dizzy episodes. So now we're going to talk about spontaneous episodic vestibular syndrome. Again, the second strata in the red rectangle. Now, vestibular migraine is a benign peripheral possible etiology to spontaneous episodic vestibular syndrome. How do you make the diagnosis? From Table 3, page 13, you need to have at least 5 episodes of moderate to severe symptoms. These can last between 5 minutes and 72 hours, quite a wide time span of duration. A history of migraine headaches is common. The migraine headache features should be seen with at least 50% of the vestibular migraines. So headache with migraine characteristics and aura, phonophobia, photophobia, or some type of visual aura. Meniere's disease, also a peripheral benign etiology. Patients will have vertigo and drop attacks related to this disease state. There can be tinnitus, hearing loss, ear pressure or pain. It's usually unilateral. It's treated with salt and fluid control. And at times there's external devices or surgery that may be required. So Meniere's unilateral hearing loss, a simple way to check for hearing is to move your fingers one ear on the other. And if they say they can hear it on one side and they're deaf to it on the other, that would suggest possible Meniere's disease. Now, we are talking about spontaneous episodic vertiginous syndrome or symptoms. If it's episodic, spontaneous, it could be a posterior circulation TIA. This is more central, a more serious etiology. Up to half of posterior circulation TIA patients have dizziness as the only symptom. And the symptoms can be related to the long brainstem tracts that are found in the CNS. There can be some CNS nerve dysfunction or cranial nerve dysfunction. There can be visual field cuts because the posterior cerebral artery supplies the visual cortex, and in the presence of ischemia, there can be visual field cuts. And these patients are considered high-risk TIAs as compared to those with anterior circulation because it can progress quickly to a posterior circulation stroke with the attendant complications seen there. There are some rare spontaneous EVS diagnoses such as, or less common, cardiac dysrhythmias, pulmonary embolism, seizure disorder, or panic attacks and/or anxiety disorders. And I have to comment that although these are listed as rare, these actually are more common disease states that you must consider with spontaneous, episodic, vertiginous vestibular syndrome presentations. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following: A, associated symptoms, T, timing and triggers, ES, examination signs, and T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV, or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and/or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the Nystagmus findings, significance, and BPPV maneuvers, Hallpike and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the fern.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.